Hello and welcome to part 2 of the Adrenal Gland lecture series. This is lecture 4 in the endocrine system lecture series. Okay, jumping into the glucocorticoids, the cortisol in the zona fasciculata. Remember, the zona fasciculata is the middle portion of the cortex, and it's going to be responsible for the sugar. Remember, outside we had the zona glomerulosa, which dealt with salt. The middle is the zona fasciculata, which deals with the sugar. And then the zona reticulata, which we'll talk about later in this lecture, is the sex hormones, like testosterone, estrogen, and progesterone. Okay, so cortisol. Cortisol is a wide-reaching hormone, often known as the stress hormone. Its job and its responsibility is to help maintain blood sugar in the long run. Okay, so like insulin, glucagon is more of the short term, kind of the ups and the downs as we eat throughout the day. Cortisol's job is really to keep everything level all the time, and depending on what's going on and what situation that we're in, determining how much glucose we contain in our blood at any given time. So it's going to act on all of the systems: the brain, the liver, the muscle, the adipose, the immune system, the bone, the skin, the cardiovascular system, the pancreas, the GI system, the kidneys, the reproductive system. All of it is impacted by cortisol. Okay, and you can take a minute and kind of look through all of this. But we'll dive into a couple of these different spots here as well. But you can see, like, we increase gluconeogenesis. We also are trying to increase glycogen, storing up the glycogen, decreasing insulin, dealing with proteins with the lipase tissue, doing bone reabsorption to try and maintain certain levels, dealing with the kidney, with the heart, all of these different things, the sleep-wake cycle. All of these are involved with the cortisol system. Down below, I have a lot more extensive notes kind of diving into all of this. So again, my notes are in the description. You can fill out the link, and I usually try and get those out every single day once I have processed that. So some of the other physiological effects, the big ones that we'll consistently talk about, are the cortisol is an anti-inflammatory process. Using cortisol is designed as an anti-inflammatory, which is why we use like a cortisone shot, similar chemical makeup, cortisone, prednisone, dexamethasone. All of these guys are steroids, which can be used either injected or taken orally to reduce inflammation. So cortisol is one of those, it helps reduce inflammation. Other big effect that it does have is it's known to depress the immune system. So we'll kind of look at that later. So cortisol, the way that cortisol gets around, we already covered this very, very briefly. We have these CBG, the corticosteroid binding globulin, as well as albumin, that cortisol binds to in order to go through the bloodstream. It's how it gets to all the places that it needs to go. So we see with the plasma protein bound cortisol, the free cortisol in the plasma, the adrenal system is correlated in here because the adrenals are releasing the cortisol into your pituitary system. We saw that. What isn't shown in here is is also kind of the other systems. The connection that it has to some of the other zones. But again, for this kind of surface level type course, we're not doing a super deep dive into the exact workings of all the interconnectedness of those systems. Cortisol is also one of the cortisol's big responsibility is monitoring and assisting us in our circadian rhythm. This is kind of our sleep-wake cycles. So it fluctuates throughout the day in what's called a diurnal pattern. So it's a reoccurring pattern that happens every 24 hours. So we see our cortisol levels tend to spike up in the morning, and then they taper off and go down and down and down as we go about our day. and then while we're sleeping and resting, while we do physical repair, all that kind of stuff, then our body revamps cortisol again right before we wake up. That's why it's response. If we're constantly at a high stress level, if you ever tried to go to bed when you're really, really stressed out, it can be very difficult. Feel like you're sitting there lying awake for hours. And that's because if your cortisol levels are really, really high, then your circadian rhythm can be kind of messed up because you're having very high cortisol levels, which typically is keeping us, awake, prepping us for the day, rather than allowing us to wind down. Food intake also, assists with kind of cortisol cycle, keeping everything level. So with every time that we eat something, regular meals and snacks also help us, self-regulate the cortisol levels. So here, breakfast, snack, lunch, snack, dinner, snack, to keep it, more sustained, having a sustained energy level throughout the day, and better sleep at night. So talking to all of you who are watching this video, who have not eaten breakfast today or lunch today or have not gotten a snack, it is okay to do so. Make sure that you fuel your body so that you can get done the things that you need to do. As well as go get a glass of water. If you haven't drank a glass of water today, go get a glass of water, start drinking it. It's very important in the long run. Okay. Release of cortisol is controlled primarily by the brain, the hypothalamus. Any of these kind of stress type things going on, sleep, cold exposure, pain, emotions, hemorrhage, exercise, hypoglycemia, trauma, infections, toxins, etc., etc., etc. All of that is registered by the hypothalamus, gets passed down. The message gets passed down to the anterior pituitary and gets released into the adrenal gland. Looks like the computer's running a little slow today. There it goes. So corticosteroids and relative glucocorticoid and mineralocorticoid activities. This is just kind of this is just the chart. You don't need to sit here and memorize all these different numbers. This is just kind of comparing them between each other, kind of looking, at their average concentrations, how much is secreted, just so you can get a look. Comparing them side by side. Cortisol versus corticosteroid, aldosterone, all of these guys. Pathology for cortisol. So we're going to look at one big pathology, the main pathology that we look at. There are a lot of pathologies correlated to cortisol, as well as the next lecture that we go over is the pancreas. So cortisol and kind of its role with managing blood glucose, as well as pairing that with our pancreas and our insulin resistance. There's a lot of conditions that correlate all into that kind of those ideas. We're not going to get into them in this lecture series. I'm going to mention a couple of them just so that, if you're curious and you want to see kind of the connection between these things, as you will be seeing real life patients who will be dealing with a lot of this stuff, I encourage you to kind of go down those little rabbit holes and start looking at, at these different hormones and how the current state of affairs of diet and exercise levels and activity and all that kind of stuff, general, life balance, affects cortisol, affects insulin resistance, affects, our hormone levels, because there's a very deep rabbit hole that you can go down. And being knowledgeable about these hormones and kind of how to help control them and help keep them normal and help to bring them back to normal levels can make a huge difference when we're talking about patient care. And a lot of this can be done, from a conservative standpoint, with diet, with exercise, with physical therapy, with the chiropractic adjustment. All that kind of stuff is tied within all of this. So looking at excessive cortisol, I believe we're going to talk about excessive cortisol here, and then we're going to jump back, like I said, kind of about Addison's disease is more of the hypo side of both cortisol and aldosterone. So with excessive cortisol in excess again causes insulin resistance, as well as increase in hepatic gluconeogenesis. I have insulin resistance in here twice. There we go. It leads to glucose intolerance, as well as it's tied directly to diabetes. It's huge, talking about immune system, depression. This is why after finals week or after a really, really stressful period of time, you tend to get sick because your cortisol high stress levels continuously sustained drops your immune defense, and you tend to get sick immediately after once the cortisol levels drop off. Suppressed inflammatory response can also mask severe infections or issues. You can get mood swings, anger, depression, that kind of stuff in association with cortisol. Some of the diagnoses, we want to check the ACTH levels, we want to check the plasma cortisol levels, and also adrenal angiography, taking a picture of the adrenal glands themselves to see what's going on. Excess of cortisol production is known as Cushing's. Now, there's two different conditions. There's Cushing's syndrome and there's Cushing's disease. This is just like earlier when we talked about primary, secondary, tertiary. This is what's getting into Cushing's syndrome is a primary disease, meaning that the adrenal gland itself is the issue. It can either be because of a tumor in the zona fasciculata, again, that functional adenoma that we talked about, this is excreting excess. You can also get what's called iatrogenic Cushing's syndrome. That word iatrogenic, you're going to hear it a ton. That means physician induced. A lot of times we think about medications and stuff that we use. Oral steroids are used a ton across all different professions, medical professions, for control of a whole bunch of different issues. Most of the time, if you go into an emergency room or something and you have musculoskeletal pain, the first thing that they're going to do is throw a dose pack at you. The dose packs are kind of those pills where it's, you take 5 one day, then 4, or like 6 one day, 5, then 4, then 3, then 2, then 1, and you kind of tone it down. It's the goal of that, is to decrease inflammation, help with the pain, all that kind of stuff. The downside with that is a lot of people don't follow the dosing properly. So a lot of times, they'll take the first 2-3 days and they're like, I feel great, and they stop taking them. The issue with that is when we start to introduce, let me write this down here, when we introduce external steroids, our body reads this as having enough and turns off making it ourselves. So you can see an issue if cortisol is really important in making sure our blood glucose levels stay aligned, stay good, helps with our sleep cycles, all this kind of stuff. If all of a sudden we throw that out of whack, it can be really dangerous. Our glucose levels can really get out of hand. We can start to sleep really, really poorly, and it can lead to a whole host of other problems. So that's why if you're going to do any kind of steroid pack, or if you have patients taking steroids, make sure that they continue to take the correct dosage and they don't just come off of it and they follow the instructions on it, because it can have really, really bad effects if you don't do that. And that's kind of what iatrogenic Cushing syndrome is. It's when you put somebody on a steroid medication, oftentimes like a long-term steroid for conditions like arthritis, either rheumatoid, psoriatic, Reiter's, that kind of stuff, ankylosing spondylitis, those kind of inflammatory type arthritides. The inflammation that you're going to be having with those conditions really becomes an issue if they're on those long-term steroids for a long time, and if they try to come off, because then the body has stopped essentially producing its own steroids. As well, you can have what's called an ectopic production of an ACTH-like hormone from a malignancy, from a tumor. Most commonly, this is a small cell tumor of the bronchus, so it's known as an oat cell carcinoma, small lung cell tumor, small lung cell cancer, any of those kind of wordings can have this. Now, this is a little bit confusing, so I've had a couple different professors and different sources. Some say that it's primary, some say that it's Cushing's syndrome. Other sources say that it's actually Cushing's disease. So, talk to your specific professor and see what their idea is on it. Obviously, if we have a patient with cancer, we want to get them to an oncologist to make sure that they get checked out. But, whether or not it's primary or secondary, make sure that you check with your specific professor to see how they're going to test it, because I've seen it as both. Finally, secondary Cushing's is known as Cushing's disease. This is an issue with the ACTH tumor in the anterior pituitary. Again, that functional adenoma tumor. Cushing's disease is much more common. It's like 70% of the cases of Cushing's, whereas Cushing's syndrome is only about 30% of the cases. So you're more likely to see Cushing's disease than you are Cushing's syndrome, but make sure you know how to differentiate the two. Again, Cushing's syndrome is a primary disease of the adrenal gland itself. Cushing's disease is an issue with the anterior pituitary gland. Signs and symptoms of Cushing's. I'm going to point out the ones that most commonly get tested and that are most commonly recognized. You'll have hypertension. You get these cutaneous striae, so like these lines, oftentimes like on the belly or on the breast tissue. You get what's called a buffalo hump fat or buffalo hump fat pad. Kind of that spot in the back of your neck right there. If you've ever seen a buffalo, they have like that extra big hump on just behind their neck, so that's what starts to develop with Cushing's. You also can develop what's called a moon face, and kind of see how round the face becomes, very, very large and rounded, as well as you get centripetal obesity. Oftentimes you'll see that the limbs themselves tend to get thinner, and the central part of the body tends to become more obese. You also do get very thin skin, fragile skin, so people tend to bruise a lot easier or they get injured a lot easier. These are all signs and symptoms of Cushing's. Another patient video if you want to take a look at that. A couple other conditions that would probably be worth your time, especially in today's world. Both with cortisol and insulin resistance. PCOS is a really, really big one. You should probably take a look at, involving, with cortisol, insomnia, sleep apnea. Some of these conditions are loosely correlated with cortisol levels and cortisol issues, so take a look at those as well if you have a little bit of time. This is not, typically not testable material, but just they're very, very common conditions. PCOS is incredibly common in women nowadays. Sleep apnea, I would argue that probably, I'll look up a statistic. Let's see, what percentage of people have sleep apnea? Right now, according to the National Sleep Foundation, sleep apnea affects up to 20% of the population. So 1 in every 15 individuals have a case of sleep apnea. That's the ones that are diagnosed. So it's a lot of people. Sleep apnea, you'll see so many people have sleep apnea. A lot of it has to do, with insulin type resistance, with obesity, with postural issues, with muscular issues, all sorts of, with chronic inflammation, all that kind of stuff. Okay, now the hypofunction. We saw hyperfunction of cortisol. Now let's look at hypofunction of the adrenal cortex kind of as a whole. We get what is called Addison's disease. Previously, this was most commonly caused by tuberculosis, wreaking havoc on the adrenal gland. Nowadays, it's typically more of an autoimmune type condition, and you'll find circulating autoantibodies, so self-attacking antibodies, in 50 to 75% of all the cases. And of course, this is a primary disease because the adrenal cortex is directly affected. There are some secondary causes of hypofunction of the adrenal cortex, like Nelson syndrome and Waterhouse-Friderichsen. Those aren't really covered in this course. They're touched on in the future. They're not super common and not ones that, typically get brought up in most courses. So, as well as they're rarely tested on boards or other big exams, and they're pretty rare to see. So, just know that they exist, and eventually they'll come back around. Now, hypofunction of the adrenal cortex. All these effects are due to reduced adrenal hormones like cortisol, aldosterone, and the sex hormone production. Hypotension, tachycardia, orthostatic hypotension, meaning that when you go from sitting to standing or laying down to standing, you get a sudden drop in blood pressure and can cause fainting. Reduced stress tolerance, a weaker pulse, GI issues, anorexia, vomiting, nausea, those kind of things. As well as with Addison's, you get bronze coloration of the skin, like the face or the sun-exposed areas of the body, or anywhere that there's also a crease or a fold. So, oftentimes, in the elbows, on the knuckles, anytime the place that the skin folds a lot, elbows, you'll get this different bronzed coloration of it. President JFK actually had Addison's disease, so that's why when you look at him, his face was very, very tan due to this condition. So these are all the general ones. Big ones to remember. If you can remember what each hormone does, you can think, okay, what is caused, what does each of these do? But these are the big ones you'll want to remember: the hypotension, the GI upset, the bronze coloration of skin, as well as weight loss, weakness, that kind of stuff. Those are the big ones you'll want to remember. Complications of Addison's disease. Big one is known as adrenal crisis. So this is more of an acute Addison's type disease due to any of these factors. There's that withdrawal of cortisone medication right there. Management of this is oftentimes done in the hospital, where you have to restore the fluid and electrolyte balance. Hormone therapy, as well as getting the high sodium, low potassium diet. Again, because if aldosterone is super low, we're not reabsorbing that sodium. We're actually losing a bunch of the sodium in our body through the urine. Okay, big ones. Remember, again, you need to know Cushing's, difference between syndrome and disease. Make sure that you know what Addison's disease is and some of the key factors of identifying it. Next, we have the androgenic steroids, DHEA, from the zona reticulata. And produces that DHEA, also known as androgen. So, with the sex hormones, essentially, you can see this in adults or in children as well, and we'll see a couple different issues with it. So it's more significant in fetal development of male sex organs. In females, it's responsible for pubic and axillary hair growth. It can be used, this is talking about adrenal androgens as a whole. It can be used as a precursor for testosterone. Any kind of abnormal secretion we get in men, we get premature puberty, and in females we get ambiguous genitalia. Okay, and we'll see these come back again when we get into more like the reproductive type stuff. There's two different kinds of. We only really talk about hypersecretion of the adrenal androgens. So that's what we're going to talk about here. So hypersecretion, we can have either acquired or congenital. Okay, so the acquired is typically due to a tumor which secretes the androgens. Because you get a ton of androgens produced, you tend to get more testosterone produced. So because you get a bunch more testosterone, you see more male characteristics in females. You get what's called hirsutism, which is male-like hair growth on like the face, the chest, and the back. Acne, amenorrhea, or like oligomenorrhea, so irregular periods or a lack of period. you get clitoral hypertrophy, decreased breast size. In males, you get progressive virilization as well. Virilization meaning more pronounced male-like attributes. So, the hair growth, balding, just more masculine-like features in general. In the case of congenital, this one you have, it's typically due to, whereas acquired is typically due to some kind of tumor. Congenital is due actually to a deficiency of an enzyme, a 21-hydroxylase deficiency. Typically, it's deficient from chromosome number 6. So I'm just going to read directly through this. So decreased cortisol due to the blocked 21, this enzyme. This feeds back to the anterior pituitary and causes increased production of ACTH because it's trying to increase cortisol production, but because cortisol production is blocked, this leads to increased production of androstenedione and testosterone. Okay, so essentially you get a bunch of extra testosterone. So in the female infants, you get ambiguous external genitalia. Looks like this, where this is technically a biological female, but because of the excess testosterone being produced, it does not look like that. In male infants, you get enlarged genitalia, as well as what's called an infant Hercules. So this child here, infant Hercules, looks very, very strong, excess muscle development, all that kind of stuff, as if somebody, like a male going through puberty, because they're having a bunch of excess testosterone in their system. And and they also get accelerated growth and sexual maturation in male children. Both of them, get the progressive virilization, those male features, accelerated growth, as well as early epiphyseal closure because of the excess of testosterone. So here we have kind of this whole process laid out, the ACTH coming down, cholesterol typically produces to progesterone, and all through here to produce aldosterone and cortisol. But because this enzyme is blocked right there, that enzyme 21 hydroxylase, all of this instead gets pumped directly to testosterone. So the pathway, we're trying to produce more cortisol or trying to produce more aldosterone. So we're going into this pathway, and we're going into this pathway, but then because that pathway can't continue, we can't convert the progesterone and the 17 hydroxyprogesterone to the aldosterone or cortisol. It just gets funneled along and turned into the androstenedione, which gets converted to testosterone. So that's the big issue with this. That's the main conditions. That's with adrenal glands, is the hypersecretion of the adrenal glands. Finally, I want to talk about something that is a little bit more broad. This is more what's called a functional abnormality of the adrenal gland. This isn't pathology of the adrenal gland itself. It's a functional type issue. There is something called general adaptation syndrome, GAS. This was first proposed by an individual named Hans Selye. You absolutely need to know this name. Not necessarily just for this course, but for the future. For if you're in chiropractic school watching this video, Hans Selye is a very important individual who goes over general adaptation syndrome, and it does come up consistently on boards, especially part 2. So general adaptation syndrome is a 3-stage process that the body goes through when exposed to stress. There's an alarm phase, the resistance, and then an exhaustion phase. Okay, most of the time we go into alarm phase, and then our body will go into resistance phase, and then the stressor will pass, and we'll go back down out of the alarm phase and back to homeostasis. But sometimes we can continue passing and reach the exhaustion stage, and that's when bad things happen. During the alarm phase, this is our fight or flight. So activation of the adrenal glands cause the release of the epinephrine, norepinephrine, and if it's sustained, you can also actually get enlargement of the adrenal cortex. So fight or flight, think like PTSD type situations, they're having severe issues adapting to the situation. They're constantly on high alert, constant sympathetic release. You get this you get stuck in this cycle of fight or flight, and that can put a lot of stress on the adrenal glands and cause hypertrophy of the glands themselves. That's the first phase, the alarm phase. After we've gotten into the alarm phase, our body tries to correct everything with our hormone balance, everything acting on everything else in the resistance phase. So the body tries to adapt to ongoing stress by returning the bodily functions to pre-stress levels using the parasympathetic nervous system, that autonomic nervous system, responsible for reducing cortisol, lowering the blood pressure and the heart rate. All of that kind of stuff is connected in this whole process. If we are unable to return back to pre-stress levels, stress more along the lines of some kind of external situation in which it puts stress on the body, not necessarily just like stress. If we're unable to go back to where it was, and especially if it's for an extended period of time, the body's no longer able to fight the stress, and you actually get damage to the body, or individual parts of the body may start to shut down. So you can actually get collapse of vital systems. You can have failure of electrolyte balance. Suddenly your body just shuts down and unable to produce hormones that you need. And you can actually get structural or functional damage to vital organs like the adrenal glands, like the liver, like the pancreas, like the kidneys, like the brain, all that kind of stuff. So this is our general adaptation syndrome. We just covering the super basics of it here. You'll get a lot more into general adaptation syndrome in the future. Try kind of 7 is when you really take a deep dive into general adaptation syndrome and all of that. One sec.
You're here by yourself.
Okay. Finally here, the abnormalities. This was an extra slide that was in here. Kind of reminder, we've seen this exact slide before in terms of when we looked at the thyroid, just like the different hormones. So we take a look at this. So primary, secondary, tertiary type issues, if it's the gland itself, the anterior pituitary, or the hypothalamus, just play with this as well. Make sure you understand when something is low, why something else is high. So if the adrenal gland itself is the issue, it's not producing the hormones, even though the hypothalamus and the pituitary gland are trying their best to keep it all going. And that is the end of the adrenal hormones presentation. Thank you so much for watching. Make sure, if you have any questions, leave comments down below, or go ahead and leave a like on the video as well. It really helps out. And also, kind of encouraging to help me keep making these videos. So have a wonderful day, and good luck studying.